Hi, everyone. Today we are excited to be talking with Shobhna, who is a BCBA working in the school setting and also has a background in clinical psychology and mental health. So welcome.
Hi there. How are you guys?
We're good. Happy to have you. Can you start by telling a little bit about you and a little bit of an introduction?
Yeah. So my name is Shobhna Srivastava, and prior to being a BCBA, I still am a licensed clinical neuropsychologist, and I worked in this field. So I think I got my license in the year 2009, and I had been working in this field right before moving to the US in 2016. So I taught for a while. I taught a graduate program for about a year. The specialty for clinical psychology in India is called MPhil in clinical psychology, and then you are kind of associated with an organization called the Rehabilitation Council of India that kind of licenses you and gives you the license to practice as a clinician there. I was a part of a couple of hospitals before I moved to the US, and one of them was this big multi-specialty hospital, and we had like a whole gamut of patients coming from which had like comorbid mental health conditions from cardiology, neurology, internal medicine, just general medicine, and of course psychiatry. So I also worked for this really, really great hospital, which is down in the southern part of India. It's called Chetana Hospital. It's one of really, really good psychiatric setup that you have down in the southern part of India. And I was a part of the clinical psychology department there. So a part of my work entailed, of course, therapy, cognitive behavior therapy. And as a part of my job, I was also doing diagnosis and certification of kids on the spectrum, of kids who had other mental health conditions. So a lot of IQ assessments, a lot of assessment for kids on the autism spectrum, kids with ADHD, kids with learning disability. And I would also conduct neuropsych assessments for people going in for surgery or who have had a history of tumor or traumatic brain injury. So neuropsych profiling of them. So that was what my work entailed back in India. Then I became a mom, and I decided to kind of pause. And my husband had other career plans, so he said, "Do you want to see, and you want to come with me and see how it is there?" And I was like, "Well, I am on a break. I would not mind a change." So that is how I moved to the United States. And while I was on my break, I had some time and I would read. So since I was always a part of this assessment and certification, I was always interested in the rehab part as well. So after I diagnosed and certified, I was really, really curious as to what happens next. So I tell you that probably these are the deficit areas and these are his strengths. What is the next step? So I started reading about it, and I came in contact with my program director, and I did my coursework from University of Washington, and we exchanged a couple of emails, and the rehab part and the teaching part got me really, really interested, and I knew it would be a different career path altogether, and I was not sure if I wanted to do that, but it really intrigued me. It got me really interested. So even when I was sleep deprived nursing my child, I would still kind of find time to read up an article. And that told me, oh my God, this is really interesting, because if I'm doing this when I'm tired and I'm sleep deprived, I must really like it. So then I decided to take a plunge, and here I am.
So what a cool background. I have always, wanted to practice psychology. Yes, I took psychology at school and went into the behavioral track, but I've always been the opposite and said, wow, I'd love to get in the diagnosis piece. And I love to, start with families and counsel families from the diagnosis to treatment. Mm-hmm. So it's really awesome that you have that background. How does that help you now as a BCBA? I'm sure that it just makes you understand things so much more from a whole gestalt point of view.
So that's a really interesting question, Shayna, because so the kind of referrals that I've been getting, if I can say that, if I'm allowed to say that, they're not like quote unquote straight jagged ABA cases that we learn during our school. All the kids that I'm working with now have either they are not on the spectrum. Very few of them are on the spectrum. They either have a history of traumatic brain injury or they have a trauma. They have a trauma. They have just a big underlying trauma that is resulting in a lot of behavioral challenges. They have a lot of functionally family dysfunction going on that is resulting in a lot of behavioral challenges at home. So my background in psychology just helps me get a really comprehensive gestalt picture of how things are working, and to look at an individual not in an ABA, just from this ABA perspective, but also this whole comprehensive background about the family, about medication, about how the IQ report looks like, how, even so, if you tell me that, hey, the WISC score, when I look at the IQ report and the case manager tells me, hey, his verbal IQ is really high. And then I look at the WISC reports and I say, oh yeah, the verbal IQ looks really high. But then when I look at the subcomponents and then I look at one of the subcomponents, and then I'm able to kind of relate, probably it is because of this, it is because of the overall verbal verbal part looks really great, but here is what is causing what is causing the academic challenge. So that really helps me formulate a case a lot better. It also helps me. So now when you're working with schools, you're working with like big teams, okay, people with a lot of different ideologies, different personalities, and just different perspectives. And sometimes it just becomes very challenging to get everybody on the same plate, everybody talking, not even if not talking the same language, at least, just being on the same page. And that, and I was able to kind of utilize a lot of my prior expertise to just talk and communicate with the team, talk and communicate with the parents, just to let them feel safe, disclosing information with me, and just feeling comfortable. And I think once you have that piece settled out, I think when you're working with schools or with parents, when you have that piece taken care of, it's a big chunk of work out of your way, and then you can just focus on the child, and you're not dealing with the other logistics. So that really helped me, understand the nitty-gritties of human communication, how big teams work, how do I better understand the IQ score that has been given to me, or how do I look at the neuropsych report and tell them, hey, you know what? So I'll give you a really, really, it just happened to me. It just happened last week. We've been working with this kiddo for a while, and we were just having a hard time communicating with him. And I was just wanting to have a look at the neuropsych report. He has a history of trauma, like a very, very severe head injury. So finally, I was able to get the neuropsych report just last week, and I discovered that the part of the brain that governs the speech was impacted. And that could also impact the hearing. And he has not been tested for the hearing. And I was like, I'm not really sure. And he was just, the way he would, the way he would come across, he would look at you, he would smile at you. It would look like that he was understanding and he was communicating. But then we figured out that he was probably his right side, the right side of his brain was working far, far better than the left side. So he was able to kind of hear from one side of the ear and not so much from the other side of the ear. And all I had to do was to position the BT on his left side, where he was at least able to hear her well. And and I was like, oh, this was I would not call it a small fix, but then this changed a lot of things that we were struggling with. So at least now we now we at least know that he's listening to what we are saying, and then we can have programs in place.
And that's massive. I mean, sure, it's a small fix, but it's massive that you saw that.
Mm-hmm.
And with your background, you're able to, pinpoint things like that. You mentioned that, schools have big teams, and, some ABA companies have big teams as well. But, we always stress, the importance of a multidisciplinary team. And it's exactly for that reason. So you're super fortunate that you have that background. But if you don't, and if you are practicing BCBA out there, and if you have access to more people, than just other BCBAs working with you, grab them and utilize their skills, because everybody sees something a little bit different, and that can really benefit your learner.
Yes. And, so often, at least I felt as a BCBA that there were so many things that I was just guessing, without having a background in clinical psychology or being able to test certain things and being able to dig deeper. Sometimes it just felt like we were guessing. And so being able to know really why, things are happening. And I think, like you said, there's no cookie cutter kid who is just ASD, who you do the typical ABA stuff. Like, every child comes with so much more individuality. We're learning more about mental health and autism, and how that, plays a factor into how we treat or how we do ABA. How do you find that ABA and mental health overlap and complement each other in what you do?
I think you really cannot, you cannot really understand ABA in a vacuum and then mental health in another vacuum. They have a lot of overlap that really happens. So I'm sure both of you would have also encountered there are a lot of kids, apart from having a diagnosis of autism, they also have a lot of trauma associated with this with their behavior. Like this kid that I'm working with currently, and I had an opportunity of observing it at different times during the day. And there would be times where the extent of his escalations was really high. The intensity was really high. The duration was of him engaging in challenging behaviors was really high. And in all my observations, and I found that there was something telling me that he was really uncomfortable in his body. He would fidget. He would, he would play around with his pants, and he was really uncomfortable. And then I asked the case manager, and I was like, I do not really see him use the bathroom even once. I've been here 4 hours and different point in time during the day. I have not seen him use the bathroom even one time. So can we just figure more about it, and can we find out more about it? Turns out that he had trauma associated with using the bathroom with something that had happened in the past. And now imagine an 8-year-old child being in a full day school, not being able to use the washroom even once, just because of the trauma associated with it. And he has all these, challenging behaviors in terms of property destruction, in terms of, aggressive outbursts, in terms of swearing and, destroying academic work. And when we started shaping the bathroom behavior, the challenging, we had other things in place, but shaping the bathroom behavior really helped him de-escalate much faster, because we had a lot of antecedents in place, and he was using the bathroom. He was trying to use the bathroom appropriately, and that got a lot of things under control. So I think there is a lot of overlap when it comes to just understanding the child. And the second one that I really feel is of prime importance is as professional, if we can address something called the caregiver's burden. In terms of parents, who have kids with special needs, they experience a tremendous amount of caregiver's burden. And sometimes it just comes across as, I cannot collect data, or I cannot do this for you, or can you not do something simple for me? And this is just too elaborate and it's taking a lot of time. I think what they're trying to communicate is that my platter is full, and I just am burdened with, just managing my life around, and can you just make it easy for me? So addressing that piece has been, I would do that as a therapist a lot, because we would work with family members of adults who had like chronic psychiatric illnesses. But as a BCBA, I've always tried to address, be it the case manager or be it the parents, is there something that really that I can do to make your life easier and not add on more work to it? So that is the second piece. The third piece that I also feel is that as you work with older kids, kids who are high functioning, they come with with a myriad of really, really complex mental health needs. They are lacking a lot of skills, but they also understand that they're lacking a lot of skills. And that has, I've seen many kids who have, just because of the understanding that they have, the insight that they have into their quote unquote problems, they're depressed and they have a lot of anxiety. And this, you cannot just say that just because he's on the spectrum, anxiety is a comorbid situation, or depression is a comorbid situation, or OCD is a comorbid situation. He probably has insight to what is happening with him, and it is a residual outcome of that you see. So there is a lot of overlap. How you want to deal with it might differ because the two approaches are different. But certainly there is a great amount of overlap.
Such good points. And you have said a lot of things in there that I want to parse out and talk about even more. One of those things is, you're right, like with some of our kids who have a ton of language and really do have an understanding that, they have a diagnosis of whether it's autism or whether it's something else. It can be difficult, and that in and of itself could cause trauma, or could be traumatic for them. Other times, it's like depends on how they're told, and they embrace it, and it's great and wonderful. Because the last thing we want is for our students to use their diagnosis as an excuse to not do things. At the same time, though, like, what do you do in those situations? How do you build up their self-confidence so that, they can embrace their diagnosis versus like, oh, yikes, this is a burden I have with me that I need to carry along?
So my first step to that towards working with anybody, be it an adult or a child, is to have a really, really robust rapport, just to build that it begins from having a working relationship where the child allows me into their space, to having this really, really robust rapport. Then I go about talking to them and telling them that, all of us, and so what I have found helpful is that if you equate a mental health condition with something that people experience on a physical plane, it is easier for them to understand. So, for example, if you equate this, hey, so there was this person, and an adult that I was working with was on the spectrum, and we were helping him with job placement. And he would often say that, I would not get this offer because I'm dumb. I would not get this offer because I am autistic, and this and that. And there was this one time I said, would you have said this to yourself if you had diabetes, that I will not end up, or I would not, find this job offer because I have diabetes, or, I have probably some other physical ailment. And he turned around and he told me that, no, but that's there in my head. I cannot take out being dumb from my head. And we had this whole conversation about finding a good fit for you. I said, not everybody is made to do everything in the world. You have to find what interests you, what you think you are good at, what something that you can, that you can really contribute towards. It's just about finding a good match. So just having this conversation about normalizing somebody's experience and making them feel comfortable in their own body really, really goes a long way.
And I think with the other examples that you mentioned earlier, it's also about, as BCBA, sometimes we can focus too much on the behavior and just look at the behavior and forget the big picture. And sometimes, if you're not looking at the entire individual, meaning the caregivers and the individual and their backgrounds and, anything they may have gone through and any other diagnoses, you may miss solutions like that with, the bathroom example, and thinking about what their home life is like and thinking about where they're coming from and why they may be engaging in these things, as opposed to just looking at it as, well, don't reinforce this behavior, or I need to follow through. And so I think we need to think bigger and start to incorporate some of these things that you're referring to in what we do. So I love those examples.
You also mentioned, caregiver burden, and that's also massive. I did a whole CEU on this a few months ago, and it's in our behavior resource. But it's, so many times as a therapist, it's really easy to say, I can't believe that parent doesn't follow through. Why? It's so simple. Why can't they just do, and sometimes you do catch yourself saying that. And then you need to take a step back and say, whoa, wait a second. Let's look at the whole picture. Like, what does this caregiver have to deal with on a regular basis? What else do they have on their plate? And, sometimes something so tiny, or something you think is so tiny, like just do this one little thing, can feel like, what's that saying, the straw that broke the camel's back, right? Can just feel so enormous. Mm-hmm. And, then other times, you get, somebody who says, well, we need all these data, so fill out these 40 forms and, you can just do that, no problem. And it's like, whoa, that's a lot, right? So we really do have to recognize that caregivers can't do it all.
Yeah. The other thing that has really helped me, the open meeting, whether it is with the case manager or with the parents, I never even have a pen and a paper in my hand. I have my hands open and I just listen, because I do not like walking into somebody's home or into a school just as somebody else who's just there to collect. I mean, as ABA, we are big on collecting data. I said, but you know what? I can rely on my memory. I can have that written down, probably a while later, but I never do that. And I've never done that as a therapist as well. That, when somebody's talking, I am busy writing and I'm not making an eye contact. And I feel that it's just, it just takes that human warmth out of that conversation, which I feel is very, very important.
Oh, it's such a pet peeve for me when people sit in a meeting with a parent who's talking about their child in front of a computer and, typing away while not even looking at the parent. And like you said, or like just having a data sheet and a clipboard. And we need to remember that we're human beings first, and that matters more than the data. And you know what, even if the data are a little bit inaccurate because we were having a conversation, that's okay. And I think that I love that point. And if more people became human beings before they were BCBAs and left their computers in their offices, I think we'd be better off.
Bridget Taylor and Linda LeBlanc they have a research paper out on compassionate care, but they also do webinars and they do talks at different conferences. And if you ever see them speak, that is one of their things, right? Like the Cooper Bible doesn't have, anything about communication and talking with parents and all of that type of thing. And, it shouldn't, it's a different slant, but we really do need to know that. And I think, going forward, part of the exam, or at least part of your supervision, as a BCBA wannabe, is having to do some compassionate care training and here's how you talk to parents. And when parents are having, an emotional moment, that's not the time to like send a text on your phone or be typing on your computer. It's about putting your laptop away and being open, right?
I think our field has come really far in all of these areas, and being more empathetic and compassionate and, considering things like mental health and trauma-informed care. But if there was one thing you think the field still needs to improve on, what do you think that we could still do better in?
Or we can have a separate podcast.
Oh, wow. I know, there's a lot.
So, you know what? This is not a great question. Now, what I'm seeing now is that a lot of BCBAs and a lot of clinicians in our field have become more open to the mental health approach. Like, for example, I see a lot of, like, I've seen both of you also talk about acceptance and commitment therapy. Now, technically, this is not a defined dimension of ABA, but we are incorporating that, and especially with adults who have a lot of language, who have a lot of insight, and so one is that. The other thing that I when I was doing my program, I felt that when you are behaviorally defining, when you're writing behavioral definitions, there are multiple times I see that the private events are so difficult to define, but they play such a crucial role in how the behavior looks like. So I was wondering, if you can if you can come up with finding a way of behaviorally defining how anxiety would look like, or how anxiety kind of, reflects with this person, or how depression looks like in a particular individual. Because I've had older kids come up and tell me, hey, you know what, I need a mental health break. And I was like, what does that mean? And they will tell me that this is exactly, a lot of it is a lot of internalized things that you would not see overtly. But I was like, oh my God, I wish there was a way we could behaviorally define, if behavioral definitions were so important, or be like more accepting of just private events, and saying that we do not probably have a very concrete behavioral definition, but this is impacting the behavior. I think that would be a big step.
Spoken like a true psychologist. But yeah, no, I agree. I think that we miss some things when we just focus on the behavior. And I've seen kids who, like, it really is just anxiety. And if we can treat it like, they're anxious or they're nervous about something, and not treating it as they're kicking, screaming, tantruming, then I think we could do better. But how do we as a field define that? I don't know. That's a great direction to go.
Do you have any resources that you would recommend to either newly minted BCBAs or ABA professionals?
Oh, how to ABA. That is my to-go resource. But I think there have been talks about incorporating the PECs into the behavioral protocol. But if the BCBAs, there's this if the BCBAs have insight into or some direction into PECs training, especially when they're working with like little kiddos who do not have an SLP working with them currently. And, you see a lot of behavioral challenges just because they cannot communicate, or they have no words, or they have just no ways of communication. I think that is something that can be incorporated. I'm not saying that you do a whole piece of that and you become specialized as an SLP, but even just an introduction to it, or just an insight as to how it is done, so that the child can learn to communicate. That is something I really found helpful. A bunch of books, and you guys already have mentioned that on your on your website. I enjoyed reading this book called A Will of My Own, and Smart but Scattered.
Mm-hmm.
That's another.
I like Smart but Scattered. I don't know A Will of My Own.
Yeah. It is. I would not say. There's this another book. I do not know how helpful it would be to the behavioral specialist, but I enjoyed reading this. How to Talk to Kids That They Listen.
I've read that.
Yeah. So I have something really interesting to tell you. My son caught me reading this book. And he likes flipping through a lot of my books. So he looks at this books. He finds me reading this book, and he says, "Oh, so now you're learning ways on how to make me listen to you better." And I was like,
busted.
And I was like, yeah, busted totally. This is exactly what I was doing.
Yeah. Don't talk to my kids. Like they're already all BCBA'd out. Like they don't want to be reinforced or sticker charted.
Yeah. So if he sees a token economy, like my son, if he sees a token economy chart, out of my bag or somewhere, he's like, that's not working for me. I know what's that for.
Yeah. They figured me out.
My daughter writes her own schedules now. She'll take a whiteboard and write out schedules for herself. But yeah.
Okay. Well, Shobhna, thank you so much for being here.
Thank you so much for having me here.
It's so nice to have you here. And also, your participation in our community and what you contribute there and our mentorship. So thank you for being there too. And thank you for sharing with us.
Thank you. You guys have a lovely day.